This is a clinical case. This woman, 69-year-old female, non-smoker without any comorbidity, presented to me in the month of June last year. She had cough since 2 months and significant weight loss, around 8 to 10 kilograms. So she got a chest X-ray, which was suggestive of a left upper lobe mass. And then she underwent a PET, which was suggestive of a left upper lobe spiculated mass around 5 centimeter with lytic bone lesions with some mediastinal lymphadenopathy and a minimal left pleural effusion. So we did a biopsy. It was suggestive of spindle cell carcinoma of the lung, a very rare disease, and it is a subtype of sarcomatoid variants of lung cancer. So because this is an uncommon pathological subtype and it is usually not very responsive to chemotherapy, so we didn't go for EGFR, or ALK by conventional. We sent an NGS. We had the discussion with the patient and we waited for 2 weeks, and surprisingly we had an exon 14 skipping mutation positivity, and it took us around 2 months to import the drug. The patient was started on capmatinib through compassionate access program, and I'm very thankful for Novartis for that. After 3 months of therapy, so here's the PET, which we have a significant response, a significant decrease in size, as well as SUV uptake. And she had a little bit of pedal edema, which is a class effect, I would say. And we had to reduce a little bit of dose, but more or less she is tolerating well, and with diuretics and all that, and she's quite better now. She's gained at least 6 to 8 kgs. She's back to normal. Her ECOG PS has improved probably now, I would say 1 to 2, and when she came to us it was around 4. So I think so this case, what teaches us is, number one is, if you have somebody with this uncommon histologies like spindle cell or sarcomatoid variants, then I think so you should be definitely suspecting this mutation. Overall, you might find it in probably less than 3 or 4%, but in this subset, approximately 16% patients in some series have this mutation. So I think so this.
Just a thing, would you like to test in other spindle cell other than
sarcomatoid? Yeah, definitely, because
okay.
it is enriched in this subset, definitely. Otherwise, I'm doing a NGS for all my metastatic NSCLC patients,
okay.
And that would definitely catch it. But for those subsets, probably you should be more suspicious for this mutation. And now we have a targeted therapy for that. I think so that's one of the reason we should be more even more inclined to test for this mutation.
Dr. Priyanshu, Dr. Alok here, if I can make a comment on this.
Yes, sir, sure, sir, thank you.
So I just want to add one thing. It's good we do NGS for those tumors which are rare, but when interpreting the result of NGS, we should know that on all the tumors, these might not be a driving mutation. So where the data is available for driving mutations, so a lot of time what we are happening, we are now getting NGS report and we are stuck after NGS report because we don't know whether it's a tier 2 mutation or tier 1 mutation and whether it's a driver mutation or not. So it's good to get NGS done, but we should use the data judiciously, and we should not keep on because these are expensive therapies, and a lot of our patients will not be able to afford them. And while waiting for CAP program, we are making the patient progress on therapies. So based on the data we have, we should order NGS and we should know how to interpret them. So we have to be careful using NGS for all the patients.
Definitely, it's a very valid point. And I think so it's a off-label. I mean, we can use crizotinib also, although I'm not very sure that it's also not so cheap, I would say. But now it's available, so I don't think now you should wait for a compassionate access program. Now you can start it directly.
No, I'm just saying about other variants, other type of sarcomatoid variants which Dr. Navdeep asked. So I said ki in those rare cases where we don't have data, we should not just rely on NGS report where we don't know whether it's a driver mutation or not.
Definitely, sir. Definitely. So thank you, Dr. Navdeep. And now we proceed to the